G'day, I'm Dr. Bruce Watts. It's May 2024 and today we're going to do a little bit of education on syringe drivers, Nicky pumps as they're commonly known, and have a little look at what goes in them, how to look after them, and some of the do's and don'ts. First of all, who was Nicky? Nicky was nobody. It was actually just a brand. It was a German manufactured syringe driver, and for the last 40 years in Australia it's been the dominant brand. And so it's come to be known as a Nicky pump. It's actually been bought out by Becton Dickinson. It's now called the BD Bodyguard T syringe pump, although lots of people seem to refer to them as a Nicky pump still. So first of all, why would we want to use a syringe driver? Well, commonly where you've got a patient who's got nausea or vomiting, can't tolerate their oral meds or are not absorbing them, they may have gastric holdup or gastric or intestinal edema, particularly in the setting of right heart failure, or they may be struggling to just swallow themselves. They're all candidates for a syringe driver. It also has a number of advantages, so it avoids the need for frequent injections, particularly in palliative care where they can be painful and quite common. You can put multiple drugs into the syringe driver together, so that a butterfly can be sited and stay there for days or even longer sometimes. So they're all advantages of it. It has a faster onset, of course, than taking tablets or an intramuscular injection. You can adjust the doses fairly easily with a syringe driver. Next thing, how do you site a butterfly? So generally the rule of thumb is you want it to be subcutaneous. So first of all, make sure the line is primed right down to the needle. You want the needle to be dry, but the tubing to have the drug and fluid in it, so that when the syringe pump starts, there's not a delay before the patient starts getting the actual boluses of medication or the continuous syringe driving. So once you've got the line primed, the general rule of thumb is pinch an inch. So grab some flesh from the tummy, make sure there's no muscle that way, and then insert the butterfly at 45 degrees, make sure it's subcutaneous then, and we typically put a little bit of cotton wool under the butterfly wings and then tape it down securely to make sure it stays at that 45 degrees, and then you're not giving an intradermal injection or an intramuscular injection. There are a number of sites that you can use. So typically we use the lower part of the abdomen below the umbilicus, but you can use the thighs, upper arms, on the back above the scapula, subclavian on the chest wall. You do want to avoid places that are near a joint, near nerves or blood vessels that you're aware of. Stay away from the axilla, and then you'll generally find an effective syringe driver. Lower legs are a poor site for them. You want to be higher on the thighs. The absorption from lower legs can be a bit sketchy. Remember that if the patient has subcutaneous edema or lymphedema, that's going to inhibit the absorption of the drug quite significantly. All right, on to the main event. What drugs are you going to put in your syringe driver? Well, first of all, the number one thing that we're trying to manage is pain, especially in this palliative setting. And the drugs that go in the syringe driver are typically morphine, hydromorphone, and oxycodone. Dr. Blight, who's our wonderful palliative care specialist here, suggests that she normally would use hydromorphone as her first choice, has a slightly lower rate of causing nausea or vomiting, and it has the advantage that if the patient is in significant renal failure, it doesn't have the buildup of toxic metabolites that's sometimes can occur with morphine. So if the eGFR is below 40, you want to avoid morphine and try and use hydromorphone. Generally speaking, what we do with doses is have a look at what the patient has been receiving in the days before, convert that to an oral morphine equivalent, and there are oral morphine equivalent charts available online. If you Google it, the Western Australian Health Department has a really simple chart that's easy to use and comes up right near the top. And those charts will give you an oral morphine equivalent dose, and then you're going to convert it to a subcutaneous dose of the drug that you want. So you will see a bit of variation in morphine equivalent charts about the conversion ratios. Dr. Blight suggests that with oral morphine, the dose of oral morphine is 3 times the subcutaneous dose of morphine that gives you the same effect. With oxycodone, it's 2 times the dose of the subcutaneous oxycodone. And with hydromorphone, the oral dose is 2.5 times what the subcutaneous dose would be to get the same effect. So we suggest that you perhaps follow that guideline if you're not sure. Hydromorphone sometimes causes some redness at the butterfly site. It's a kind of a chemical irritation rather than necessarily infection. If you put a little whiff of dexamethasone into the pump with it, it will often stop that happening. It doesn't mean that you need to pull the butterfly out and keep reciting it every day. Typically, if the patient is entering a late stage of their palliative care and a pump is instituted, it's commonly because their pain relief is not working very well. So whatever doses they've been getting, sometimes you need to increase that a little bit in the pump on your first day, and you can certainly titrate it, increase the pump dose through the day if you need to. All right, second symptom, nausea and vomiting. How do you manage that? Dr. Blight suggests that it's worth being a little bit preemptive with it. She says she normally puts haloperidol in with the morphine or hydromorphone right from the start, usually 1 to 2 milligrams, and that goes in the pump, and it helps alleviate or prevent nausea or vomiting, particularly in the patient who's a little bit sensitive to a narcotic. If you need more antiemetics than just the haloperidol, you can add Maxilon, and a common combination is put Maxilon, metoclopramide, with the haloperidol into the pump, and those two can go together. If that's not settling, you've got a few other options. So cyclizine, the antihistamine, is effective, available as a subcut, usually 50 milligrams 3 times a day. You can also add it into a pump, but cyclizine generally needs to have its own line and its own pump. It's often not compatible with the other drugs in the pump. Another option is to give boluses of ondansetron, usually 4 to 8 milligrams up to 4 times a day, and that can be very useful to try and help settle intractable vomiting. If you get to that point, it's very worthwhile adding some dexamethasone. So dexamethasone is usually a stat dose, 8 to 16 milligrams. There's a bit of variation. There doesn't seem to be a absolute right or wrong. And dexamethasone has a 72-hour half-life. So whether you give it as an oral stat dose or an injectable stat dose doesn't really matter too much. It does not need to go into the syringe driver. Dexamethasone, once it's on board, will potentiate the antiemetic effect of the other drugs. All right, third symptom, agitation. Patient is anxious, agitated, irritated. First thing you want to do is just check if there's something causing it that you can remedy. So check their oxygen saturations, make sure their respiratory rate is not elevated, make sure they're not short of breath and fighting for air. You can alleviate that simply with some oxygen. You want to check their blood sugar level, make sure they're not hypoglycemic or hyperglycemic. You also want to just check the bladder. So a common circumstance in this situation is that there's urinary retention, and that will make everybody agitated pretty quickly. Obviously, if they're in pain still and you haven't relieved their pain, there may be significant agitation. Worth checking pressure areas as well. Do a survey, pull the blankets back, check if the patient's got something in the bed that is sitting badly against them or they're resting against the side rails. What drugs do we use for that? Usually midazolam is first line, so 5 to 10 milligrams in the syringe driver. Occasionally it's more than that. You can use a bolus of midazolam subcut. I usually use 3 to 5 milligrams. I generally find the 5 is more effective than 3. There's a rare circumstance where a patient will respond paradoxically to midazolam and actually become more agitated. So if that happens, you need to switch to clonazepam. And clonazepam is quite a reasonable alternative to midazolam. Lots of units will use that as their first line instead. Usually 0.5 to 2 milligrams over 24 hours will go in the syringe driver. And if the patient needs a bolus, 0.5 to 1 milligram subcut. And that will just help them feel relaxed. It will both those drugs will make you a bit drowsy. There is a third option, which is phenibub in terminal care. That would be something that you probably want to get specialist help with before considering. Next, secretions or gurgly respirations, a common thing that happens in pal care and often quite distressing for families to watch and listen to. Dr. Blight says there is evidence for doing something preemptively about this, being a little more effective than waiting till the patient is really gurgling and got a lot of secretions that they don't reflexively swallow. So hyoscine or buscopan, typically 40 to 60 milligrams would go into the pump over 24 hours, or a 20 milligram bolus if required. An alternate to the buscopan is robenol or glycopyrrolate. Usually in the pump would be 600 to 800 micrograms, and 200 to 400 micrograms would be used as a subcut bolus. These drugs are not super effective, but they are a little bit more effective if used early. Another thing that you can do is tilt the patient up, get the bed down like that, get them on their side with their head tilted to the side, and give it 5 to 10 minutes, and just see if you can actually drain out some of the secretions that are pooling in the back of the pharynx. Suctioning out the patient, putting a Yanker sucker down their mouth and trying to get the fluid out is generally quite distressing for the patient and typically doesn't seem to relieve their gurgling very effectively, so it's not generally recommended to do that. Last symptom that you may be coming across is seizures. So usually a bolus dose of clonazepam will settle that down. If you don't have it, midazolam will do a similar job. If you have intractable seizures that are not settling down, we typically go to Keppra, and Keppra again should have its own separate line, not part of the rest of the pump medications, and that can be titrated up to control seizures. So just to finish off, common question from patients and sometimes staff and families is, if my patient goes onto a morphine pump, a syringe driver, will I make them die quicker? Is it going to shorten their life and finish things off? And the answer is the evidence seems to suggest that it doesn't particularly do that. In fact, some studies show that if you are effective in relieving the difficult symptoms in palliative care, that the patient may actually live slightly longer. It's not a statistically significant increase in their life expectancy, but you can be reassured that the pump is there to relieve symptoms. It's not to knock the patient off, and it doesn't do that. It doesn't hasten their death. Do's and don'ts with a syringe driver. Don't get it wet. They don't go in the shower. Keep it out of the sun. They are injured by shock, so don't drop it. Make sure it's secured. So if it's in the bed, it should be somehow at least tied to a bed rail so that it can't be knocked onto the floor. If the patient is ambulant, you want it in the shoulder holster so it can be carried safely. The pumps are worth more than $5,000 each, so if they get damaged or wet or ruined, it's very expensive replacement. You also just want to make sure that the case is locked, just so that you can't accidentally get a change in the dosage, or sometimes patient deliberately wanting to change their doses. So you need to make sure that's locked securely so that only the nursing staff can adjust that. What do you do if the pump stops working or the alarms are going? First of all, just check that the tubing is not kinked. Check that there's not crystallization or blockages within the tubing. Make sure that the butterfly itself is not kinked. So a very common thing for the butterfly is to retract from the skin just a couple of millimeters and then form a nice little Z-shaped kink in it, and then the butterfly is a blockage point itself. So have a look if you need to take a dressing off to inspect the butterfly site. Do that. The butterfly site, we typically change them every 3 days, but they can be left longer. Sometimes some units will leave them for 2 weeks if they're not red and there's not a problem with them. But you can make your own rules with that one. When the low volume alarm sounds, don't panic, because there is generally 1 to 2 hours of actual medication still left, so it gives you plenty of time to go and reload, get ready for the syringe driver. All right, good luck, and hope things go well with your palliative care. All the best.